All right, it's Healthcare Unfiltered. It is completely unfiltered. And here we are with Dr. Ishwaria Subbiah on this podcast. Ishwaria, you were with me on my older podcast, Outspoken Oncology, that we rebranded in Healthcare Unfiltered. It is possible this is your first appearance on Healthcare Unfiltered. So welcome to the show.
Thank you so much. Happy to be here in any incarnation. I'll gladly break bread with you.
Okay, so Dr. Subbiah, Ishwaria Subbiah, we'd like to have just a little bit of an introduction, first of all, to viewers and listeners. Some of us are viewing this on YouTube, others are listening to this. We've known each other for a while, but some folks may be listening who don't know your career path and really the inspiring things you've been doing. So take us through how did you end up where you are now? And you can start from as early as you want.
Sounds good. Sounds good. It's life is always interesting, right? So I'm a medical oncologist and a palliative care physician. My work has always been at that intersection of symptom management and cancer outcomes, whether it's standard of care treatment or clinical trials. And over the course of that, one of the elements that I've found I enjoyed about the work is finding ways to proactively identify the needs that our patients may have and how we can mobilize the health system, whether it's that individual clinic unit, that department, that division, how we can mobilize the infrastructure to proactively meet the needs instead of waiting for patients to have to bring a need up to the surface. And so it was in that same frame of mind that I found myself working in the professional well-being space. It was why do I feel frustrated? Whether it's at the end of a workday or a couple of weeks on inpatient or, whatever period of time, like why am I having these, frustrations that I'm taking with me on the drive home or thinking about them after hours. And that's when I started exploring what professional well-being truly was and what the workplace experience was. And it was really an eye-opening learning experience for me, just to read about this space and then to live it in administrative roles. And so this summer, I made the first really major move of my professional career. For 15 years, I was in Houston, Texas, a bulk of that time training and on faculty at MD Anderson, and it's an amazing experience. And in that mid-career stage, as with many people in the mid-anything stage in life, there's a restlessness, there's an uneasiness. It's the beginning of a steady state. And you're either a steady state person or you're not.
Or not, let me tell you.
And steady state to me, I mean, no one wants turbulence for the sake of turbulence. And so, but the steady state to me that was not a good thing was more of the same versus true growth opportunities, new challenges. And so I joined, took a job that I could not come up with reasons to say no. And the only reason I could come up with was I'm too chicken or I'm too comfortable where I am. And I joined Sarah Cannon Research Institute in Nashville, Tennessee. So my husband and I are Nashvillians and Tennesseans. It took me a little while to get that one. But
is there a Nashville? There's a Nashvillian, huh?
Nashvillian is I really hope I didn't add any vowels there, but and been here since this summer, 6 months or so in the role, and 4 months or so in living in Tennessee. And my enthusiasm, my love for the work is as strong, and if not more. And so my job is as the executive director for cancer care equity and professional wellness for the Sarah Cannon Research Institute network. And I have a joint appointment over at US Oncology as the medical director for supportive care oncology, health equity, and professional well-being. these
Great.
are
Well, congratulations. This is an amazing step. And I look forward to seeing a lot of the wonderful accomplishments that you are going to do. Um, for context, just for my viewers and listeners, I want to make sure that we're taping this in December 2023. So it may be airing sometime in 2024. So there may be some delay. I say that because by the time they listen to this, you would be in Nashville for a little bit more than 4 months. Um, so we'll talk a little bit about your role on the cancer equity, because I do think it's important, because your view of this is a little bit different, and I got to learn from you about this through an article first I read in Wired magazine, which I thought was really beautifully written. How do you spend your? Do you see patients? Is it main administrative work? How do you spend your time?
I've thoroughly enjoyed the time that it takes to have a medical license processed. So I took a brief, just a couple of month hiatus from patient care, and it worked out well because it really needed to set up the office and set up that framework for our work in the near term, and then the strategic planning for the long term when it comes to clinical trials access, but also in the professional well-being space. And then, you get the email. Congratulations, your Tennessee license is now, issued, and
There you go.
so I look forward to jumping back in the clinic in a very focused way. And with our new practice in Nashville, Sarah Cannon Research Institute Oncology Partners, SCRI Oncology
So
Partners.
what kind of patients would you see? Because
Yeah.
you're, I mean, in palliative care, you could see everybody, right? I mean, so you see all type of cancers being referred to you, mainly outpatient or inpatient or both?
So I take care of people across settings of care, hospital,
Right.
clinics, home, even hospice.
Okay.
So in that way, the continuum of care is really depending on the patient needs. And so from and I've spent some time reflecting on this, because it was like, okay, do I wear the oncology hat? Do I wear the palliative care hat? Do I wear a little bit of both? And where I see the real opportunity for program building and growth, especially in our new practice that's hitting the ground running Monday morning, is really to have that overlay of supportive and palliative care, that symptom management overlay
Mm.
in a thriving, energized clinical oncology environment.
Mm.
And so I'll be taking care of our patients through the symptom management lens, and partnering with my colleagues for their disease management part.
So I asked you to come on this podcast because I was very intrigued by your role as on the wellness front, because there are a lot of folks who would, raise their eyebrows, like, what does that even mean? And we're going to go over this, right? So you started actually telling me, interestingly, that, you were wondering sometimes, as you're driving home while you're in Houston, what is it that's actually happens that maybe makes you more down or something of that nature. So what was it? I mean, as you searched internally, did you find why this gets to you?
So, the work that's been done around burnout in medicine, the work that's been done on the workplace experience outside of healthcare, it was a series just of everyday, day-to-day events. These events aren't even significant enough for me to even remember them. But they're the micro frustrations that we all feel over the course of a typical workday. That can be in the context of patient care, it can be in the context of research duties, it can be in the context of educational responsibilities, administrative responsibilities. There are these micro frustrations where you haven't done anything wrong per se, but somehow something that should be working or something that should happen seems to be an uphill battle. It's requiring more of your energy than you think is right. And it's taking time and that bandwidth away from something else you could be doing with that time and bandwidth. And so it was these drives home can be that time for some introspection to just, wrap up the day. And what I found myself thinking of was, these are these inefficiencies in day-to-day work life that are needing me to take extra steps, spend extra time, that don't actually translate to advancing the mission, whether it's against
But is
cancer,
that really burnout though? I mean, like, I mean, look, I mean,
burnout. Yeah, agreed.
what is really burnout? I mean, you could go to I don't know, some place and you wait in line for like half an hour, and it's frustrating. I don't want to wait for half an hour. But what is burnout? This is not burnout. This is just, hey, it's like, everyday living.
So what we're describing is that those individual experiences that aggregate over time. Burnout is not a overnight event. You don't become burnt out overnight. It's not an entity that it happens as a direct response to a single catastrophic event, whether it's a personal loss or a professional loss, just as an example. Burnout as a clinical syndrome, as a psychological construct, it's depersonalization, right? Emotional exhaustion, and that finding meaning and value in the work that you're doing. It's loss of the meaning and value in the work. Emotional exhaustion, depersonalization, where your reactions in that moment, it may be entirely internal or subtle, you're finding yourself becoming a bit harder, a bit more calloused, a bit less responsive to what you're observing. Burnout is not something that happens overnight. There's a lead time anywhere from year to decades. And
So a burnout could be like I become like I don't care anymore.
you don't care anymore.
Right.
You don't care anymore.
Is
You feel exhausted.
Yeah.
Just don't care.
I mean, do you think, is there data that burnout exists more in the medical profession versus finance, agriculture, whatever it is?
Yeah.
And within medicine, are there data that, which type of specialties have more burnout than none?
Yeah. So we're overdue for a comparison across professions for sure, because the pandemic had a very unique and deep impact on the healthcare profession as a whole. And one can argue that those elements of emotional exhaustion, depersonalization that manifest and aggregate as burnout were really accelerated over the course of the pandemic itself. What we do know from historic data is that when you looked at the general working population in the US and compared the resiliency scores of them and that of physicians specifically, doctors had among the highest resiliency scores of all the professions that are out there. And this becomes crucial because our workplace experience, this entity that is burnout, medicine does not have a resiliency deficit. Medicine does not have a resiliency deficit. Healthcare professionals, by design, whether it's their innate abilities or the trainings that they've been through and got to this point in life, they have amongst the highest resiliency scores to start with.
You mean it
And
takes us longer to burn out as doctors?
it's one where our ability to adapt and cope, when you compare it to the general population, is already high. What this one study that I have in mind showed was that with every incremental increase in the resiliency score, the likelihood of burnout by definition did decrease. So there's an element of protection that you have from building habits that foster resiliency. But what it also showed was nearly a third of the physicians who had the highest possible burnout score highest possible resiliency score. I misspoke. A third of the doctors who had the highest possible resiliency score were still showing symptoms of burnout. So what that tells us interpreting this is, A, medicine does not have a resiliency deficit. As a field, physicians at baseline have among the highest resiliency score of other professions compared to other professions. The second is personal resilience is important. There are elements where it has protective features to help mitigate burnout. But because a deficit in resilience is not the actual reason behind burnout, those who even have the max score for personal resilience still had signs of burnout. So from a causative standpoint, an underlying reason standpoint, you have to look beyond telling the doctors and the nurses and everyone to meditate and mindfulness practices and all of which are important, but that's not the root cause.
I mean, we'll go into why we think we have burnout, but again, I mean, I think some might argue that, look, you guys, I mean, you chose that profession. That profession just comes with that. I mean, it doesn't have to be that bad, but it comes with this. Like, I guess, do you have studies or data or something on percentage on, if I take 100 doctors, do we know how many are burnt out? And how do you differentiate burnout, because you may have certain things going on in your life outside of your work? So, is it really work burnout, just overall something happening in your entire life, or do we care? Burnout is burnout. I mean, I guess I'm trying to quantify to listeners and viewers the extent of the problem. I'm trying to understand, is there a problem? Are we exaggerating the problem? And if there is a problem, what is the true incidence, prevalence of this problem? Because we don't want to create an issue that is not there. So help us quantify it and qualify it.
Absolutely. Burnout is a word that's in the colloquial vernacular. And so, it's probably on some random commercials for vacations or whatnot. Burnout is a psychological construct. There are validated measures on assessing, measuring emotional exhaustion, depersonalization, and an aggregate burnout score. The studies that have been done in this space have consistently shown anywhere from 30 to 60% of physicians demonstrate meeting the criteria for burnout.
Wow.
So from a prevalence standpoint, we don't have to go far
That's high.
to find someone who actually meets the criteria for burnout. It's the difference between using burnout as a word by itself in a question and actually asking questions that bring out that hardening, that emotional exhaustion, that depersonalization. The second thing is, you're right, there are any number of reasons why a person, any individual can be under stress. When you're looking at the numbers that we're looking at for prevalence of burnout in physicians and in healthcare professionals overall, you can't tell me that 60% of people have something happening at home that they're, intensely worried about. And not only from us thinking through as a perception, if we were to hypothesize, but the data also shows it. Because when you measure the professional well-being in your people, you're not just asking a single item burnout question. You have to ask about the subdomains that we know impact the workplace experience. And this is where there's a robust body of data on the importance of control over schedule, personal organizational values alignment, organizational leadership, peer support, gratitude, perceived gratitude, received gratitude, meaningfulness of clinical work. Each of what I just shared conceptually as are predictors of burnout, and have 2 to 3 items behind each of them that can actually, you can measure objectively across your people where they stand in each of these known drivers of burnout.
So then can we segment this burnout thing? I mean, can we say, okay, look, these are the specialties with the most burnout. This is the age, maybe it's more common 30 to 40 versus 40, 50, 50, 60, I don't know. Is common more men versus women? Is it more common in academia versus community? Is it more common? I don't know. I guess, do we have any data on the characteristics or the phenotype of the individual who is most likely to develop burnout?
I'm fighting all urge to just pull up some slides and show the constructs that are out there. And so there's the body of work that's done in the clinical psychology and the organizational psychology literature, which healthcare professionals may never ever come across. Combine that with the body of work done within medicine itself and within oncology, we have clarity on the framework of how to think about burnout and what we can do about it. Okay. So the very first thing is, as a healthcare community as a whole, in any role, if you're somebody who wants healthcare to work in the United States, then you're a stakeholder. Is us thinking of professional well-being for exactly what it is. And there are a couple of different frameworks. One's from the national academies, and there's one out of Mayo. I particularly like this one out of Stanford, which has personal resilience as part of a circle, important part of the circle, but it takes up about 20 to 30% of that circle space. The remainder of that pie is made of organizational factors. And the two big ones are efficiency of practice and the culture of wellness. Those are organizational factors.
What does culture of wellness mean?
This is how much are you asked to do outside of work hours? How much are you being asked to do as part of your core job function require you to take escalating amounts of time outside of work in order to meet it? How much is your workflows, your day-to-day responsibilities, how much is the system supporting you to succeed? How many disruptions, interruptions? And this is true for any member of the healthcare team.
Right.
How much are you being asked when you're on PTO? Are you even allowed to take PTO? Or are you, frowned down upon? Do you call into meetings when you're on leave? How much do you think about work outside of work?
Is
How much
PTO a real PTO or just like a fake PTO, right?
And, I was in the middle of a very interesting conversation with one of my Sarah Cannon colleagues about this. And it's not an indulgence. Weekends, sometime on the weekends, evenings, and PTO. This is where renewal happens.
Yeah, but what do you say to people who say, look, you've signed up for this. It's part of the job. Like, there are patients who, sometimes they hear about this. Some of them, they have empathy. Don't get me wrong. And some of them say, you guys are making a lot of money as doctors. And, it's part of the job. You signed up for it. So it's like one of those things where, look, if you sign up to be a doctor, sometimes you're going to be on call. How do we capture the public's empathy that there's indeed a problem here, and this is not something because we're being a bunch of doctors that whine? How do we get the public's attention to this and explain that there's an indeed issue?
Without a doubt, we have to make sure that those of us within healthcare who are living the experience row in unison. We can't be butting heads with one another about what is a reality. The exodus from clinical medicine is a reality.
That's
There
key.
was a study from a few months ago,
Yeah.
over, what was it, close to 50% of medical school graduates currently in school have no intention of actually practicing clinical medicine.
Attrition is key.
And so when you're talking about the workplace reality for our colleagues in medicine, we have to have consensus on what we're seeing. There's no two sides to the fact that there is an exodus from clinical medicine. The second part of this is absolutely no one in any profession signs up to burnout. That's beyond absurd. Nobody goes into any line of work wanting to be essentially chased out of it or compelled to just leave it all behind. Medicine is the only field of work I can think of where there had to be a rule passed that you can only work 80 hours a week during our residency. You can only work 80 hours a week. Those who survived, those who made it through with themselves intact, can't speak for families, relationships, and goals and aspirations outside of work. There's a trauma there, whether you acknowledge it or not. The fact is that when you're talking about being on call, you won't find a doctor who feels being on call doesn't align with the core values of medicine. Medicine is there for patients 24/7 because patients have health problems 24/7. And so where you see the pushback is how is it structured? How are their responsibilities being structured in the context of what's being asked of them?
Yeah. So that really, I mean, I think that attrition hits home a lot, right? Because if you're a patient and you can't really find a doctor, that's important. I also can imagine that there are scenarios where, I mean, even my own experience, sometimes you take a family member, you go and you see a physician, and you just feel they're not there with you. They're just doing it and they're clicking. They're just not there in body
Yeah.
and spirit. So a lot of people have tried to solve the problem, and frankly, from there emerged a C-suite level position. There are certain positions called chief wellness officers at some institutions. Um, I don't know what they do, to be honest. I'm not gonna lie. I think this is the role that you're taking on, whatever the title is, but essentially you really want to do this wellness. I commend whatever effort you want to do even before you do it, because I think it's really important. But I can't imagine what you would do. I think it seems like this is such a humongous task for someone to tackle. If anybody could do it, it's going to be you, Ishwaria. So, but how do you even start? Like, what do you even do? I mean, sometimes I don't want to put words in your mouth, but sometimes like there are too many patients. You still have to see them. You got a client schedule, like all of these things. So you have a big problem. You want to make sure the doctors are happy, there's no attrition, patients are happy. And I don't think you're going to solve it in 2, 3 months or 6 months. So draw a roadmap. What are you going to do over the next couple of years, hopefully moving things in the right direction?
The very first step in any organization that's looking at whether it's the turnover rate, there's always some metric, right, that matters to people who may never see a patient, that gets the well-being of their workforce, of their people on their radar. And almost always it's either the turnover rate or some sort of number on an employee opinion survey. The very first step is, as a as senior leaders in organizations, even if you have no idea what's going on, is recognizing that there is something going on and that we do need to do something about it. Anyone in the wellness role, in any type of organizational leadership role in professional well-being, the very first thing is level setting what we're talking about. Defining what professional well-being is for the organization, for the leaders, for every single employee. This is what we mean. This is what we mean when we say personal resilience. This is what we mean when we say efficiency of practice, culture of wellness. And then it's the second realization/awareness is that burnout is almost never due to a single catastrophic event. It's not due to a single catastrophic event preceding it. It's a series of micro trauma over years that aggregate to the point of that present. The third is reflecting on what these inefficiencies are for what they actually are. Meaning, the metaphor that's used often is the pebbles in the shoe, the Muhammad Ali quote, it's not the mountains ahead that wear you out, it's the pebbles in your shoe.
Oh, I like that. I love that quote.
The mountain that is burnout, that's not daunting. It's the pebbles in the shoe that will make sure that you don't have a shot at actually summiting that mountain. And so thinking of it's giving your organization that lens of just day-to-day work. When you feel that micro frustration, just pause, make a mental note, write it down to come back and unpack it. Extra clicks, tasks you're having to do. There was a time in our workflow in the clinic a few years ago with telehealth where somehow I had to be the one who plugged in the address that the patient was in so that I can close the encounter and drop the charge. The doctor had to take precious time during that visit to get the address that the patient was in, to put it in the medical record to close that visit. So I give that as just one example. As these micro events happen over the course of the day, difficult patient, abusive even, verbally abusive. We're told to just shake it off and, whatever. Nope. It's how can the system be mobilized to mitigate the injury from difficult patient, just as an example.
Yeah. And so I think we can agree. Look, I think we can agree that there are certain things that are modifiable and certain things are not modifiable.
Agreed.
So what are the modifiable factors? I guess what I'm trying to figure out, I think we have to have realistic expectations.
Of course.
Like if you have a burnout, hopefully it doesn't last more than a day. You just burn out one day and the next day you refresh, whatever it is. But what are the modifiable factors that you really think we could change? I mean, we all hate EMR. I don't think it's going anywhere. I think it's going to outlast all of us. So I don't know what we could do there. So I guess let's focus on the things that you really think you can change.
When it comes to how as an organization tackles burnout, it's going to have to be having a core group of team who actually spearhead these initiatives across the organization. And I'm going to get into what these initiatives are. At the heart of it is organizational awareness that each pebble needs its time. Each pebble, each inefficiency is not just something you brush aside. It has to be addressed centrally. Training modules, number of in-basket messages, the number of phone calls, the number of asks being made without time allocation. When you as an exercise for an organization that wants to tackle burnout, it starts with actually raising everyone's awareness for these micro events that happen throughout the day, and then setting up that pathway where they can raise awareness to that core team, and that core team can actually work on that pebble. So that example I gave you, where I found myself spending a solid minute trying to get the address into the EMR, was connecting to, when I spoke to my clinic director, he said, you know what, just do it. It just takes a minute. Don't worry. You know, it's okay. Can you just take care of it? Just do it. That was what I was told. I went straight to the EMR people and said, why isn't this part of the check-in process? Patients check in to the telehealth visit. Why can't they confirm their address or edit it in that step? And that's exactly what they did. Not just for my clinic, they did it across the organization. But I bet you, like I was told, it's okay, can you just do it, Ishwaria? It just takes a minute. Come on, it just takes a minute.
I think the, you know, when I try to look at burnout, I feel that yes, all of these small things do add, but the larger things that I feel we can't change is, you know, pre-authorization. Okay, I mean, that definitely spending time. I can imagine, you know, hey, you know, I've done several podcasts on the maintenance of certification and the ABIM. That's has gone nowhere so far. So that adds to it. Like there are these like larger ticket items that I feel, you know, yes, I feel there are larger ticket items. If we win those, it will subside, not undermining the smaller steps, but I wish we can tackle the bigger things. I mean, this is really what drives people crazy.
It's not an either or. And I'll tell you why, because we're experiencing this moral injury from all directions. It cannot be an either or where you have to spend an amount, as an organization, you have to spend an amount of time looking at organizational factors. And there's, without a doubt, a bucket of work that's external factors outside of the organization that do impact the experience.
Yeah.
It cannot be an either or, because the evidence is very clear. The inefficiencies of the workplace, the culture of the workplace, the impact that they have, that mediating effect they have on meaning in work and turnover intentions is more powerful than the external factors. The factor that you mentioned, prior authorization, what was the other one you said after prior auth?
Yeah, I mean, the prior authorization is
ABIM, that was the other one you said.
ABIM, so, and the EMR, like the EMR is there. It's not going to go anywhere.
Okay. So when you think about prior authorizations, that's a legislated entity. Doctors need to be front and center with their legislators. We have no real empowerment over the course of our education and our graduate medical education on the importance of advocacy. Not just your professional societies advocating, that's really important, but you as an individual, you have a right and a presence for an audience with your legislators. And let me tell you, I was on the Hill early on during the platinum shortage, and my congressperson at that time, who sits on a House subcommittee that tackled drug shortages when they were the 2 years prior with opioids, had no idea that we were having a platinum shortage in oncology, had no idea that we were trying to figure out curative intent treatment is no longer possible for a subset of the population, had no idea. There is no substitute. You as an individual, no matter what you're doing, doesn't matter who your organization is, as a private citizen, that's an identity you maintain in any role. You can have an audience with your congressperson. or their staffers. Their staffers are incredibly helpful. Get that information in front of them.
Yeah.
Get your story in front of them. They like data, but they also don't care. A story will trump data anytime.
Okay. I wanna focus on just practical steps.
Mm-hmm.
I want to try to understand. So if there's a physician, a colleague of yours, that he or she, you notice that they are experiencing burnout, they're exhibiting symptoms of
Mm-hmm.
burnout, what advice do you give them? Like, aside from go take a vacation, because they may not be able to take a vacation. So what is, like, what can someone do? What can I do
Yeah.
to reduce my burnout?
One of the most effective programs that are out there is actually with peer support. Those colleagues where you're seeing something, that's already reactive, right? You're seeing the signs. So whatever is happening is happening. But having that peer supporter, and there are programs and ways for healthcare professionals, physicians including, to have very focused training as a peer supporter, as part of a peer support network. It's that ability to have an audience to articulate what it is you're going through, and that person that you're sharing this with having the training and the questions to get to the bottom of what this person's experience is. There is no take a pill and solve it. There's no take a pill and solve. There's no surgery. There's no radiation. There's no instant solution for this.
Yeah, I mean, I'm just thinking, like, what behavioral stuff I could do.
You have to be able to, this is where that personal resilience domain matters, but why it matters is you have, with understanding what professional well-being is, 70 to 80% organizational factors and 20% personal, you have to be able to, you can raise your awareness for how much of what you're going through being something that you should be doing differently versus it's a system. It's not you, it's a system. Why are you internalizing the frustrations? It's not you, it's a system. Why are you carrying the weight of a patient not getting what they need when it is nowhere in your control?
Yeah.
It's not to
Uh,
say you don't empathize. Empathy is a tough concept, and that's a separate conversation. But it's not that you don't feel bad for them, and you're doing what you can, but you can't carry that weight with you, because
right.
there's going to be 100 of them.
I mean, there's a lot of, I mean, like, sometimes I see online and other things that the institution, they bring you bagels and cream cheese to the staff lounge, and this is as a way of reducing
Yeah.
burnout, and people joke and laugh about this. You're not going to be bringing bagels and cheese.
I have nothing against pizza. I
Chocolate
I
is good.
I have nothing against adult coloring books.
Yeah.
The fact is, it's community building is an important part, and we felt it when everything became so much became virtual, right, during the pandemic. There were times where you really didn't always feel like you were a part of something. Community building is an incredibly important part for belonging in the workplace, also a measurable construct, also mediates turnover intentions. That can't be the only thing that you as an organization does for your people. It has to be putting the pizza parties in the context of a task load reduction effort, a EHR
Yeah.
optimization, or training modules slaying efforts.
Yeah.
It has to be in the context of a wellness strategy. And this is what we just launched our healthcare professional well-being strategy within the US Oncology Network.
Are you able to
And
share some of this with us in terms of strategy, like whatever you can share in terms
yeah,
of next steps?
of course. And the approach to this is as methodical as any organizational strategy development. It's what are we talking about? What's going to be the core pillars and what are going to be the tactics that we get to that? And I have to bring up one reality for, folks listening to keep in mind, and that's this entity of learned helplessness. Learned helplessness is, you're upright, you're coming to work, doing what you need to do, but you have this exasperation that things are never going to change. Things are never going to get better. So why
Yeah.
bother?
Yeah.
Learned helplessness is it's a self-preservation mechanism, right? It's just things you have to tell yourself. It's just like depersonalization, emotional exhaustion. After a while, you have to stop caring because you can't do anything about it.
Yeah.
Thinking of professional well-being in the same way, all of us to think of it in the same way, means that it gives elements of what you're feeling a greater meaning. It's not, you being skeptic or them being, dismissive. It's learned helplessness. It's emotional exhaustion. It's depersonalization.
Yeah.
Validated constructs.
I'm convinced that there's a problem. I am convinced with you about the definition of the problem. I'm convinced with you of what possibly could cause it. I remain unclear as to whether it's solvable or not. You're a palliative care physician and you treated a lot of people who were in hospice. There's a pragmatic person in me that says, I know the problem, I know the issues. I just don't know if we can really resolve it. Taking care of patients is becoming more complex, lots of specialties, lots of drugs.
Sure.
People are more demanding. The healthcare system is growing, is becoming less efficient. So part of me, that I hope I'm wrong, part of me says, despite us knowing a lot about this, and I just don't know how we can solve it. It's why I'm intrigued by a role now. I want to be very successful and make a huge impact, that when I have you back in a year or a year and a half from now, you'll tell me, hey, I told you so, and this is where things are. But genuinely, that's really where I'm at. I agree there's a problem. I really feel it, and a lot I see it, and I just don't know how we solve it.
This is a space where there's a dearth of broad awareness on solutions, and that makes it that much more exasperating. It's also a space where there isn't a whole lot of instant gratification per se. I say that with an asterisk because how often have you come across initiatives in hospitals, in clinics, in organizations that are looking at de-escalation, de-implementation, that are looking at processes by task load? This is nowhere more apparent than, like the advanced care planning stage, advanced care planning as an entity. And, there's like all this, you pick a hospital, they're talking about the importance of having advanced care planning done. How is that value translated to action? It's going to a healthcare team of doctors, APPs, nurses, being like, you need to do more advanced care planning. You need to do, because it's important, because it's important. Well, you also in the same visit need to hit all these other 30 things in addition to the cancer management and everything else. The way you would implement that in a organization that has a culture of well-being is, how can the system be mobilized to reach this goal? Oh, advanced care planning. That's the information component of that. We can share that with a patient at any point in their illness trajectory. Oh, look, there are organizations that actually have great, very brief 3-minute videos on what ACP is. Why on earth do we need to hire 100 social workers? Or we need to hire 100 social workers, period. But why on earth are we putting that on their plate and doctors' plates to introduce this concept when a patient could be home watching the 3-minute video and picking somebody in their life that they would trust to make medical decisions on their behalf in the comfort of their living room versus in your clinic. That's the difference between a organizational culture of well-being and the current way things are done in healthcare, which is asking people who are already doing a lot to do more. It's a lens. It's a de-implementation lens that is entirely possible. It's entirely doable. We don't need new technology. We do not need new drugs for this. We don't need new mechanisms of action. This is looking at the cognitive task load and just chipping it away, and move some of the mini boulders. Many of the trainings that we go through could be one-click attestations. There's no impact that's measured from them. And these are all just annual clicks. They can be one-click attestations. They don't need to be 20-minute training sessions.
Hey, you're preaching to the choir. Like I said,
But that's how you do it, right? It's not surgery or radiation. It's not even, it's targeted therapy, but this is gonna have to be a combination.
I also don't know if even that one click is needed. I mean, frankly, like we have no clue. I mean, we just do these things because they tell us to do them. Look, I think this is a lot of, it's a big topic. There was a lot of information here. And what I can do is wish you a lot of success as you start and embark on this new role. It is very, very important, clearly needed. And I would love to have you again, maybe next year, as we see, you look back and you look at the accomplishments, and hopefully that things are heading in the right direction. Because, like you said, it's not a click. It's not gonna happen overnight. It takes time, but somebody has got to do it.
Rome was not built in a day, and keep up the hope. You got to be hopeful for the future. And so one step at a time, that's it.
Well, Dr. Ishwaria Subbiah, Sarah Cannon Research Institute, thank you so much for spending some time with me on Healthcare Unfiltered. And I'm going to actually have one Muhammad Ali's quotes at the end of the monologue that I will usually do after the show. Thank you so much.
Take care.